that would be your hypoplastic aplastic anemia. Infiltration, leukemia, myelofibrosis, metastasis, dysplasia, myelodysplasia. What about macrocytic anemia and normal to low reticulocytes? That would be your megablastic, which is your folate or B12 deficiency anemia. So if it's a non-megablastic or dysplastic anemia, you want to obtain bone marrow. Macrocytic anemia and high reticulocytes, what would that be? Well, that would be from acute blood loss and a hemolytic anemia. Do you know what the Schling test is? Well, since the answer is right there, this is your 24-hour urine test for B12. Which microcytic anemia, which one of these are microcytic anemias? You can pick all that apply. I know iron deficiency, thalassemia. I think that's it. Oh. I'll have to check this one. Neurological symptoms are associated with anemia. Would it be your folic acid deficiency or your B12 malabsorption? That's your pernicious anemia, which is your B12 malabsorption. So would you be able to list the macrocytic megablastic anemias? I think you can. I would think it's like the B12 and the folate deficiency. Yep. What anemias are deficient DNA production? I feel like that's like the sickle cell. So that's the macrocytic anemias. And which anemias have a problem making hemoglobin? That would be your microcytic anemias. What are the macrocytic anemias? So those would be thalassemia. These are your options: thalassemia, vitamin B12 deficiency, pernicious anemia, folate deficiency, iron deficiency anemia. So the answer is your vitamin B12, pernicious, and folate, which is the same thing. So which anemias are normocytic? That would be your anemia of chronic disease, hemorrhage, hemolysis, bone marrow suppression. These are your lists. Which one would it be? I think it's A. Oh, because they're all anemia of chronic diseases. Oh, and then there's the bone marrow suppression, which is, again, chronic disease. Next, we have what are reticulocytes. We know that they are immature red blood cells. They are matured in the bone marrow. And 1% of all RBCs are reticulocytes. What does a reticulocyte index less than 2% indicate? This indicates either A, bone marrow suppression, B, this would be CKD, C, hypoproliferative anemia, or D, bone marrow disorders or damage such as aplastic anemia or myelodysplastic syndrome. So a reticulocyte index less than 2%. So that the index is just a measure of the production of reticulocytes, which are immature red blood cells, we said in the last one. So, but a value of less than 2% typically indicates decreased reticulocyte production relative to the degree of anemia. This suggests a reduced bone marrow response to anemia. So when we have one that's less than 2%, it's generally associated with hypoproliferative anemias. And these are the conditions where the bone marrow fails to produce an adequate number of red blood cells. So again, hypoproliferative anemias are where the bone marrow fails to produce an adequate number of red blood cells. This can occur due to various reasons. So let's see what the answer is. Oh, it's all of them. So it is all of them because this can occur to various reasons, including deficiency of nutrients essential for red blood cell production, such as iron, vitamin B12, or folate, the suppression of bone marrow by medications or toxins, or bone marrow disorders or damage, such as aplastic anemia or myelodysplastic syndrome. Chronic diseases or conditions that affect the bone marrow's ability to adequately respond to anemia is also an issue. So it's important to note that the interpretation of reticulocyte index values should be done in conjunction with other labs. So findings in medical history and clinical evaluation to determine the actual underlying cause of the decreased reticulocyte production. So yeah, that is all the answers. So what helps determine if anemia is hemolytic? So to determine if an anemia is hemolytic in nature, several diagnostic tests and clinical evaluations should be performed. Some key factors that may help in determining if the anemia is hemolytic. So let's see what the choices are. Haptoglobin levels. Haptoglobin is a protein that binds to free hemoglobin released from destroyed red blood cells. In hemolytic anemia, haptoglobin levels may be decreased. So there we go. What are important patient history factors in the diagnosis of anemia? So you're looking for family history of thalassemia, maybe a splenectomy and gallstones, any environmental exposures, any diet, specifically long-term vegetarian for like B12 deficiency or folate deficiency, ETOH abuse, folate deficiency, and then travel or sick contacts. Which would you expect to see on a blood smear for beta thalassemia? It's the Heinz bodies and target cells and hypochromic microcytic cells. Oh, aplastic anemia bone marrow failure disorder can be acquired, more common, and inherited. What are some of the ways it can be acquired? So all of the above, as you can see here. So we have post-viral infection, blood transfusion, pregnancy, ionizing radiation, drugs and chemicals, and it could be idiopathic. How would you diagnose aplastic anemia? Would you do it with a bone smear, bone marrow biopsy, spleen biopsy, CBC, or liver biopsy? Aplastic anemia. So it's aplastic reminds me of the word bone marrow. So I'm going to say B. Woohoo! Why do you check for microcytic anemias? So what do you check for in microcytic anemias. So microcytic, we already know that they are, MCV is low. So all of these, right? What is the most sensitive indicator for IDA? Serum ferritin, protein made by the liver that delivers ferritin to the bone marrow is called serum transferrin. So that is the protein that delivers ferritin, which is your iron, to the bone marrow. That way the bone marrow can make red blood cells. Okay, so what causes non-megaloblastic anemias? Chronic ETOH, liver disease, hypothyroidism, chemo. Oh, and then don't forget the antivirals, and then metabolic diseases and myelodysplastic syndrome. Non-megablastic anemias, again, are all these. Chronic ETOH, this would be liver disease, hypothyroidism, chemo could do it, antivirals, metabolic diseases, and myelodysplastic syndrome. So what is available to bone marrow for hemoglobin production? So I think, let's see, all of them. Yep, that's what I thought. So I think all of these are really important for bone marrow to produce hemoglobin. So definitely needed. Which IV iron requires a test dose? Ooh, that's the one that starts with D, right? Iron dextran. So complaints of sore tongue, glossitis, smooth red beefy tongue, peripheral paresthesias with low hemoglobin. What do you suspect? So this one is the one that has the neuro. So I'm going to say pernicious B12. Yay! Let's look at this one. You find elevated serum methylmalonic acid and homocysteine levels. What do you do? Or what do you suspect? So this is elevated serum methylmalonic, I keep saying that wrong, acid and homocysteine levels. What do you guys think? Let's see. Vitamin B12 deficiency anemia again. So this one has the methylmalonic acid and the homocysteine levels that are elevated also. Okay, so this one is going to the, I don't think this is an anemia anymore. So disease localized to single lymph node or group. Lymphoma stage 1. So again, lymph node, lymphoma, and then we know that only one group or one lymph node is stage 1. Oh, so do you remember which disease process is the Reed-Sternberg cells? Reed-Sternberg cells. Hodgkin's disease. So which disease to more than one lymph node or group to both sides of the diagram? So it looks like this one has both sides of the diagram, so I would think that it would be 3? Stage 3, yep. So what are the blood-forming stem cells called? That's like the let's see. Oh, it's the homopoietic. How is lymphoma diagnosed? What do you guys think? It's lymph node swollen. I would think that we would take a biopsy from the lymph node. Biopsy of enlarged lymph node. So this is like a typical presentation. I think I see male 32 and I automatically, my mind goes to something that's listed here. But this guy, he also presents with a chief complaint of cervical adenopathy. So what do you guys think? I know, yeah, Hodgkin's lymphoma. They're always 32 years old for some reason. Blood-forming stem cells are called, what do you guys think? I think it's B. Yes. All right. We have the most common neoplasm for ages 20 to 40 years old. So this is like the young one. What do you guys think? The younger version, the neoplasm that happens to our younger population is going to be non-Hodgkin's lymphoma. Non-Hodgkin's, 20 to 40, most common. So acute versus chronic leukemia is distinguishable from a blood smear. Is that true or false? I'm going to say true. Yes. But the diagnosis is through, let's see. I think there might be a question on that one. So acute versus chronic leukemia is diagnosed from a blood smear. We just had that one, so true. To confirm the diagnosis, we need a bone marrow aspiration because, you know, that's where we would find it. So this drug is prescribed to reduce tumor lysis syndrome in high-risk patients. This is the one that they prescribe for gout, allopurinol, the drug that's prescribed to reduce tumor lysis in like chemo patients. Yeah. So this one again, spread is predictable of this. It's cervical adenopathy. What do you guys think? I think it's Hodgkin's. Yeah, it's Hodgkin's lymphoma. So 80% of acute leukemia in adults is, I think it's the acute myelogenous leukemia. Let's see. Oh, it's both. Acute non-lymphocytic too. So AML and ANL. Which diagnoses is the Philadelphia chromosome present? Which one do you guys think it is? Chronic myelogenous leukemia. So CML is the Philadelphia chromosome. Philadelphia and CML. The hallmark sign, leukocytosis, where the white blood cells are greater than 30,000. I've seen 40,000, greater than 40,000, like example 42,000. And the median survival is 10 years. What is this disease? I'm going to say CLL. I'm guessing here, guys. Okay, great. CLL. That's the one where you have leukocytosis. All right, so pancytopenia. So this is the one that has all lows, down with circulating blasts, which is the hallmark. It is more difficult to cure in adults versus children. So O low, ALL. So I'm going to go with E. Other questions are like blood-forming stem cells are called. We have this one already. Male, 32 years old with cervical adenopathy. I think we just had this one. The spread is predictable, and Reed-Sternberg cells are the hallmark. So remember Reed-Sternberg, and that is our Hodgkin's lymphoma. Next, let's talk about cancer of white blood cells. This is the neoplasm arising from the hematopoietic cells in bone marrow. So bone marrow is leukemia. What is the hallmark of CLL? Everything. Lymphocytic leukemia. CLL is lymphocytic leukemia. We have an 80-year-old male with fatigue, I can never say that word, splenomegaly, and isolated lymphocytosis. What do you suspect the diagnosis? So I think the lymphadenopathy is the key sign here. So this would be our chronic lymphocytic leukemia. So CLL, again, lymphedema. How is a lymphoma diagnosed? Biopsy. Cancer of the lymphatic tissue with less predictable spread. This would be your non-Hodgkin's. So again, this is the less predictable spread, where Hodgkin's, there's like a predictable pattern of which lymph node. So here are some labs on hematology. What are the signs and symptoms of thalassemia iron overload? Ooh, this one is a very good question, because you can't give iron to thalassemia because it's not that they don't have any iron. So they'll have weakness, loss of body hair, so that's iron overload, weight loss, pulmonary erythema. They also have abdominal pain, thinning, darkening skin, that kind of combines with that loss of body hair, and then the joint pain, stiffness, and shortness of breath, and ankle swelling. Ankle swelling is, I always forget about that one, that could be iron overload. Okay, so how about your patient's lab results show elevated serum methylmalonic acid and homocysteine levels? What do you suspect the diagnosis is? I feel like we just had this question. So that is, again, your vitamin B12 deficiency anemia. What kind of anemia would you suspect from anorexic, alcoholics, and elderly? So obviously, when I look at all these, malnourishment is going to be my biggest one, and usually folate is the malnourishing one. So folate, yep. Factor VIII deficiency. Oh, geez. Guess what? I think is that the hemophilia A or B? A. So let's see what else. Factor IX deficiency, hemophilia B, and the Christmas disease. 9 is Christmas. Most common inherited bleeding disorder. Do you guys remember that one? Von Willebrand disease, that clotting factor that we need so much. This is also associated with TTP, because TTP has some other, so I remember that from there. So let's see here. What would deficiency in von Willebrand clinical presentation? That would be easy bruising, because again, it's a clotting factor, skin bleeding, and then prolonged bleeding from mucosal surfaces like the teeth brushing or the flossing. And I think we get that. I think that's genetic, but I think you can get it from viral, but very rare from viral, I think. So how do you diagnose von Willebrand disease? There is a VWF antigen, VWF activity, which was less than 10, I think, percent, and then factor VIII activity you could check, and then platelet function assay. That's interesting. Which deficiency? DDAVP for minor bleeding, and then what do you guys think we would give for major bleeding? So there is actually a VWF concentrate for major bleeding if you know that that's exactly what the patient has. So if you had hemolysis, thrombocytopenia, fever, neuro and renal abnormalities, and prompt the differential diagnosis of, that would be the TTP? Yes. TTP has the neuro and the fever. So which microangiopathic hemolysis and thrombocytopenia? TTP again? Oh. If you had results of a negative Coombs and your platelet counts were less than 20,000, you saw schistocytes on the peripheral blood smear, there was elevated LDH, I think we know TTP. Oh, we got quite a few like this, guys. Not sure why the screen turned this color, but TTP signs and symptoms, we will have hemolysis, thrombocytopenia, fever, and then what else do you guys think? Don't we have neuro? Neuro, yeah. Renal, and renal is like 10% of the time, but it's like always there for some reason on the board. So just remember, I think these are the 5 really big ones. Classic ones anyways. So you want to give plasma exchange because they're platelets. And then causes of secondary TTP, remember it was like medications, there was pregnancy induced, allogenic bone marrow transplant, there's like that SLE, and then the scleroderma and HIV. So ITP thinks that the platelets are foreign and wants to produce antibodies and then target to destroy your own platelets. So that is secondary TTP, and it is also known as immune thrombocytopenia, secondary TTP, and ITP immune, I think it's ITTP, and it is also an autoimmune disorder characterized by low platelet count, that thrombocytopenia caused by the destruction of platelets by the immune system itself. So platelets are essential for blood clotting, and low platelet counts will lead to increased risk of bleeding. So you're going to have reasons like drug-induced as your secondary, pregnancy again postpartum, allogenic bone marrow transplant, SLE, scleroderma, and then HIV. What is TTP treatment? That was going to be, which one of these do you guys think? It's definitely plasma exchange. What is ITP? There's a decrease in the count, absence of drug or toxic exposure. So there is a protein called ADAM TS13, which is involved in regulating blood clotting, and it actually is what works with the von Willard clotting factor. So when this doesn't have, when the ADAM TS13 is dysfunctioning, then you're not going to have the von Willard clotting factor either. So you'll see these patients have blood under their skin, which is going to be your thrombotic thrombocytic purpura. Is a rare and potentially life-threatening condition characterized by blood clots, formations, and small blood vessels throughout the body. And then it is caused by deficiency in dysfunction of a protein called ADAM TS13, which is involved in the regulation of blood clotting. Let's see, what would you prompt you to suspect ITP? Like it would be after like a viral illness, even for an adult. Before or with suppressed immune systems, like patients that are on like immune suppression medications, like SLE or HIV, AIDS. Also the lymphoproliferative diseases. Which clinical manifestations do you anticipate from ITP? That would be bruising, petechial rash, hemorrhagic bullae of mucous membranes. That's the teeth. That's the flosser that keeps, or teeth brusher that keeps having those gums bleed. And then asymptomatic bleeding. So ITP's treatment, guys, so this is going to be steroids like dexamethasone or prednisone, IV, IG, splenectomy in like rare cases, but it happens. All right, so this question is about anemia of chronic disease, MCV, and MCHC levels. Normocytic, normal, normochromic, normal. So remember, anything that's chronic is going to be normocytic and normochromic with the anemias. So these are your results that you were sent out for. What do you think this is? TTP. So you have a negative Coombs. You have platelets that are less than 20,000. Those schistocyte cells that you would find on peripheral smear, elevated LDH, and TTP. What is the hemoglobin goal for a patient with anemia of a chronic disease? Do you guys think it'll be pretty high? I don't think it's going to be that high. So it's 11 to 12. All right. So what are intrinsic hemolytic anemias? Intrinsic hemolytic anemias. Sickle cell. So like that's the actual blood cell reshaping itself, sickling. And then there's the thalassemia, right? There's hereditary spherocytosis, membrane defects, G6PPD. So I think mostly I saw in the review books that sickle cell, thalassemia are like the big ones that we will have to know. What are the extrinsic hemolytic anemias? So let's see. Liver disease, that makes sense. Hypersplenism, okay. Autoimmune. What are lab results from hemolytic anemia? That's a good question. So you would have all these increased except for the haptoglobin. Okay, so what are CBC results for sickle cell? Oh, remember that's going to have your low RBC. You're going to have a low H&H. You're going to have leukocytosis. You're going to have thrombocytopenia. So remember that one. What are transient arrests of erythropoiesis precipitated by inflammation occurs in the blood disorder? In which blood disorder? So you have sickle cell crisis, which is your aplastic anemia. So if you have 1 unit PRBC, should initially, how much would that initially increase your hematocrit by? 1 unit should increase it by 3% in an average 70 kilogram adult. So if it was like 10, which is never that, I just trying to make it easy. So it should go up to what, 13? That's not bad. That's a good help. 1 unit of platelets should typically increase platelet count by 5 to 10. Okay, not bad. So what do you guys think about plateletpheresis? So 5 to 10K with a platelets, and then this is like concentrated version. So let's see, 30 to 60K. So that's a lot. So that's like really low people. You need to use that. So what and how much would you transfuse for a therapy-induced thrombocytopenia with platelet count of 10K? Okay, so I think we're going to go with the platelet. Not the unit of platelets, but the 1 unit of platelet pheresis. What is the INR of 1 unit FFP, do you think? I guess it could increase it by, oh, so it's 1.5. How often should you transfuse FFP when administering multiple units of PRBCs? Every 5 to 6. Yep. So which blood product will increase fibrinogen? That is your cryoprecipitate. Fibrinogen cryo. Considerations for with blood transfusions when patient has a febrile reaction. What considerations? Because remember, as nurse practitioners, we are responsible for any blood transfusion reaction that happens to our patients, even though it's the nurse that is at the bedside. So we have to keep checking in on them if we order it. So leukocyte depleted blood. So considerations with blood transfusions when patients have febrile reactions is maybe order the leukocyte depleted blood. Let's see here. Which blood product would you order for thrombocytopenia due to bone marrow hypoplasia or platelet defective? Platelet concentrations. The platelet concentrations. That's good to know. And what do you think during the RBC unit infusion started on a patient? A change in patient status is reported as apprehension, flushing, pain, nausea and vomiting, rigors, and hypotension. Ooh, this is not good. Then we have circulatory collapse. So what do you guys think is happening? So there's an RBC infusion going on. I think that we have a hemolytic transfusion reaction. So which blood product would order for a specific or multiple plasma protein deficiencies such as coag? So again, like if you had the von Willebrand, I mean, you could order the concentrate for that, but there is something else you can order before that, which is your FFP. That's going to have all your coags in there, FFP. Which blood product would you order for VW factor 8 disease or hypofibrinogenemia? That is your cryoprecipitate, because that's going to have your blood, that's going to have your coag factors in it too. Which blood product would you order for plasma volume expansion? Albumin, that big protein. Okay, so what labs would you order if you suspected iron deficiency anemia? We kind of went over this already, but let's see here. We got the serum iron, because that's going to be low, right? The transferrin, that's going to be high, because when the iron is low, the ferritin also is going to be low, so which is the same thing as serum iron. What lab would you order if you suspected thalassemia or sickle cell anemias? So hemoglobin, electrophoresis, splenic sequestration is occurring, and what are your differential diagnosis? Oh, there's a couple. So we would do sickle cell, yes, definitely. TTP, yes, definitely, because that's the microclots that are happening, and the vascular And then, like, if it happens in any of the, like, arteries in the liver, it's going to block the blood flow to it. So, leukemia. Good to remember those. Okay, so you see thrombocytopenia and anemia. What are you suspicious of? Ooh, what is that one blood disease? Do you guys remember? TTP. At what point does a patient need a platelet infusion prior to going to the OR? So what is the level, guys? What do you guys think? So I have 50K per the review course, so just so you know. And then 3 units of PRBCs is what you would order if your hemoglobin was 6. Remember, it's 13% for each unit of red blood cells that you give. So the trauma patient with a hemoglobin of 6.2, what blood product would you infuse? Of course, we're going to do whole blood. What would we get FFP for? Oh, vitamin K clotting factors. If we need to do that, we would give FFP. So if you want to stop the infusion, normal saline open wide, epi, Benadryl, H2 blocker, and corticosteroids, I'm guessing that you have a blood transfusion reaction. Yep. So which of the following is not a cause of microcytic anemia? Which one do you think? Pancytopenia. The lab reports for a patient with low MCV, high serum ferritin, and low TIBC. So low MCV, high serum ferritin. So it's not low iron and low TI. So this is not an iron issue, guys. What is the most likely cause for this patient's anemia? So can't be iron. So it's not A. E. It could be B. It could be C. So the lab reports low MCV, high serum ferritin. So I'm gonna go with thalassemia because it's low MCV. Because anemia of secondary to inflammation, I would think that would be normal MCV. Yes. Oh, it says anemia secondary to inflammation. I was wrong. Where is most non-heme iron found in the body? I would say transferrin. It's bound to the transferrin. Select the following that enhance iron absorption. So we know citric acid does, and ascorbic acid. So I would say A and E. Yep, E. There we go. What is the most important test for iron stores? What do you guys think? I would think it would be the TIBC. No, it's the serum ferritin, duh. That's the iron source. Which of the following is not an etiology of iron deficiency anemia? Which one do you guys think it is? Infection. Total iron binding capacity increases in iron deficiency anemia because C, ability to absorb increases. Yay. Okay, so which lab investigations would you order if you suspected iron deficiency anemia? So I would do a CBC. I would do all of the above. Oh, just total iron binding capacity is enough just to see if it's suspicious of iron deficiency anemia. Yes. So, what are some options for aplastic anemia treatment? So, it would be these first three here. Okay, this question is on alpha thalassemia. It says, on a CBC for alpha thalassemia, you would see anemia and reticulocytosis. On the blood smear, you would see Heinz bodies, hence the Heinz ketchup, the red Heinz ketchup. Blood equals anemia equals alpha thalassemia, if you can remember that. The smear also shows hypochromic microcytic cells, and there would be occasional target cells. It says select the others that you would see increase. So others, the first four. I was going to say, since it says others, I know that it's going to be more than one, and I just think of like, test taking strategies like that. So just FYI. And then, so the reason LDH is elevated in alpha thalassemia is because there's increased hemolysis of the red blood cells. And then the unconjugated bilirubin is going to be high because in alpha thalassemia can lead to increased red blood cell breakdown, resulting in an elevation of unconjugated bilirubin, which is a breakdown product of hemoglobin. So then we have the urine urobilinogen, and that is a product of bilirubin metabolism, and its levels may be increased in alpha thalassemia due to the increased breakdown of red blood cells. So you might have that. And then urine hemosiderin. Hemosiderin is a complex of iron, so we've got to remember that word, and it's part of iron. So the protein that is released during the breakdown of red blood cells in alpha thalassemia, there may be increased breakdown of red blood cells leading to the presence of hemosiderin in the urine. And then we have the conjugated bilirubin. Now that's not going to go up because, yeah, no, I don't think it goes up. Conjugated bilirubin is typically elevated in conditions affecting the liver, such as hepatobiliary disease, but it is not directly related to the alpha thalassemia. So that's why we're not going to have that one increase. All right, so it was the first four. Here's my resources.